Hello, and thank you for tuning in to Straight Talk for Texas Trustees. My name is Susanna Ramshaw, and I oversee trustee programs and engagement for Texas Healthcare Trustees. This new program is a series of pre-recorded conversations between healthcare governance expert Pam Connect, President and CEO of Accord Limited, and THT's network of hospital trustees and executive leadership. As our facilitator, Pam will guide our participants through various issue areas affecting hospitals and boards across the state, to share insights and lessons learned regarding effective governance and leadership. Today's conversation is increasing the emphasis on safety and quality. We are joined today by Dr. Anna Buchholz-McKee, Executive Vice President and Chief Medical Officer of the Joint Commission, and Debbie Garbad, Director of Patient Safety at Houston Methodist Hospital. Welcome to you both, and thank you for joining us.
Thank you.
Before we dive into the conversation, I just wanted to share some fast facts about the Joint Commission and Houston Methodist so our listeners get to know you a little bit better. So starting with the Joint Commission, it's an organization, an independent nonprofit organization founded in 1951 that accredits more than 22,000 healthcare organizations and programs in the United States. In and of itself, it is governed by a 21-member board of commissioners. And this slide will be available for you all to download and read at your leisure on our website. A little bit about Houston Methodist. They serve an urban area, the greater Houston area, and they're comprised of 8 hospitals. They are a nonprofit academic research institute with nearly 2,400 operating beds. They have a board size of 28 members. Again, this slide will also be available for you to see on our website. So without further ado, I will hand the program over to Pam Connect. Pam, the floor is yours for Straight Talk.
Thank you very much, Susanna. Really excited about this conversation that we're about to have. Debbie and Dr. McKee and you and I had a chance to do a little bit of preparation beforehand, and I know this is going to be a really fun and informative conversation. So, Susanna, if you could go ahead and move to the first slide that has questions on it, then that will enable me to launch things off here. So the first question would be, what should the role of the board be in ensuring exceptional quality and patient safety? And Dr. McKee, I'll ask you to go ahead and start with this answer.
Sure, Pam. This gives me the opportunity to speak from a historic perspective around governance and healthcare. And if we go back to the first hospital in the United States, Pennsylvania Hospital, here in Philadelphia, in the mid-1700s was developed. And if you review their charter, the only competence that they secured in their charter was finance. Quality has been an issue that's been vague for some organizations, and we're speaking in general, some organizations, the governance structure is very much engaged in around quality, but there's opportunity for all organizations to improve in their oversight of quality and safety. Could you pull up the slide that really shows the areas where I believe are the focus areas where organizations need to really examine, are they doing the optimum? These are 4 domains that the Joint Commission has been focusing in helping boards improve their oversight and their accountability for quality and safety. The first one is transparency. The transparency has to be one such that the board is on top of all of the safety concerns, that serious events are reported in a timely way, discussed, that the corrective action plans are looked at very carefully. This is an area that then leads to improving the competency in safety and quality, which an organization, the leadership in safety and quality really should be developing a curriculum to help board members understand the significance of the data that's coming in front of them. Engagement, it means that the front line knows the commitment of that board and the priority of that board has made on safety and quality. And lastly, safety and quality have to be elevated to a strategic priority because the board dedicates itself to oversee the implementation of strategy. And so these are 4 areas where there's tremendous opportunity for governing bodies to improve in their oversight of quality and safety.
Great. Thanks, Dr. McKee. That's a really nice overview of the responsibility that boards have from a fiduciary perspective for overseeing quality and safety. Debbie, can you fill us in a little bit on how you see this playing out at Houston Methodist?
Sure. So our board is just looking at these going down in order. Transparency is very important for our board. We share our information both publicly, but also internally. Our quality and patient safety information is very, very important to all of our board members. And in order for them to maintain their competencies in safety and quality, they receive a lot of education from internal sources as well as external sources. They keep their finger on the pulse of all things quality related and safety. So they're very engaged in the work that we do in all of our hospitals. They again, they hear reports on data, they hear case studies and stories of things that have occurred with our hospitals. And they hold themselves to a very, very high standard for safety and quality as their goal for the work that they do as board members and ensuring that our organization is always improving outcomes for all of our patients.
Mm-hmm. Debbie, didn't you say that your quality committee actually has people on it that are from different industries that understand quality improvement? And am I understanding that correctly?
Absolutely. So our board members are from all different kinds of industries. We have, and many of them in healthcare, we focus a lot on high reliability as a strategy for obtaining the best outcomes that we can. And many of our board members also work in industries that strive for high reliability. They come from oil and gas, who very much has a focus on that. They need safety for their employees. We have folks with financial backgrounds, and again, quality is a very big goal in all of their endeavors. We have some religious leaders that are on our board. We are a Methodist organization, and we have some folks from that realm. And of course, they want the best for all of the people that cross our threshold. And we have some civic leaders who their charge is to look out for the citizens of Houston and the surrounding areas. Mm-hmm. And so they're very diverse. They bring lots of information and viewpoints and lots of different ways of looking at things and understanding outcomes. Patient outcomes in healthcare can get academic sometimes, and it's nice to have that outside input for what is really the best for all of our patients.
Mm-hmm. Dr. McKee, did you want to comment on that?
Yeah, I think Debbie is describing a leading practice, and organizations can secure that kind of representation on their board by having a competence-based selection process. Mm-hmm. The expert in quality does not need to be a healthcare expert. That concept is so true, to bring in someone with expertise in quality, period. But also in this country, we have tremendous leaders in healthcare, chief medical officers, chief nursing officers, who from their own careers have learned quality and safety. That's another resource for this type of competence. So I liked what Debbie said, and I just wanted to emphasize that it just doesn't happen. You have to have a process in place.
Mm-hmm. You have to be intentional, in other words, about getting the right people on the board and on the committees, and make sure that they know enough to ask good questions and insist on outcomes that make sense, I think is the other thing I've heard each of you refer to. So let's go ahead and get a little more specific to Houston Methodist and COVID-19. So let me ask you the next question, which is, what have been some of the key lessons learned during COVID-19 regarding how to improve quality and patient safety? Debbie, could you start us out there?
Sure. So many lessons that we've learned through the COVID crisis, I guess we continue to call it. I think that we'll continue to learn for years to come. But one of the very, very first things that we learned we tried to proactively learn from others. So it was a little bit slower to hit Texas. It started, I guess, a little sooner on the East Coast than it got to us. So we did pay attention and tried to learn from some of the experiences that folks on the East Coast had. And when we first had our outbreak of COVID here in Houston, our organization did just a phenomenal job of communicating. We were all learning every day, and rules and policies and processes were changing. It seemed like almost hourly, although it wasn't really that fast. But they did such a good job of communicating to all staff. It wasn't communication just to leaders. It was to frontline staff. It was to our vendors. It was to our contracted employees. Everybody was getting the information as quickly as we could get it out, and as quickly as we were learning the new things that were coming through the doors.
Mm-hmm. Good. And did you have some opportunities as a result of COVID to sort of fast forward some of the quality related initiatives that you were intending to take on?
We did. So one of the things that we're always working on and improving in our system is just really how to standardize things all throughout our system. Mm-hmm. We have programs that we push out to our 8 hospitals, and everybody has their own way of understanding things. Anyone who's worked in healthcare knows that 8 different people can read the same thing and have 8 different understandings. So COVID gave us the opportunity to really standardize and make sure that the folks were coming to the table and we all had a clear understanding before we went out to go forth and conquer. So standardization really improved by leaps and bounds through our COVID experience. The other thing that we're really proud of is our innovation. We've had a Center for Innovation for quite some time now, but during COVID, it gave us an opportunity to really, really expand on our opportunities for innovation. In our center, any person can make suggestions, and they're all reviewed and taken into account. And we got some phenomenal ideas that helped us a lot with caring for our COVID patients and with helping to keep our staff safe with the COVID that was happening and all of the PPE supply issues that were going on. We got great ideas for how to conserve and how to just expand what we had. It was an exciting time.
Didn't someone come up with a lucite box idea?
They did. So some of our critical care physicians and anesthesia work together. They have a lucite box that they can slide the patient in one side and they can reach through on the other side to intubate the patient, and it decreases the aerosolization that occurs during intubation. Therefore, again, helping to keep our physician staff and our CRNAs just a little bit safer doing the work that they do.
Mm-hmm. It's great you have a culture that it actually encourages that kind of innovation and engagement between the front line and the leadership. That's very cool. Dr. McKee, what have you been seeing as you have been contacting hospitals and health systems all over the country?
Well, I first want to commend Debbie's and her organization, and that's a description of why we call healthcare workers our heroes, for the amazing things that they have done. And from the perspective of the Joint Commission, we've seen a lot of effort from organizations around innovation and leadership. We've seen the best of leadership and we've seen the worst of leadership. The worst of leadership was reflected in the communications we get. We get about 22,000 complaints and allegations a year from patients, families, staff. And what we were hearing from staff was that they were not being heard. A lot of it was around the PPE issue, but a lot of it was describing the distrust that had occurred as a result of poor communication and poor supply chains, et cetera. That was disheartening. The good news is as time has passed, we've seen a decrease in those types of complaints and allegations. During this period, what the Joint Commission did was to work with CMS to look at those conditions of participation that really did not impact safety and were burdensome, to create waivers and flexibility so organizations could focus their attention to their COVID crisis. And we helped identify those areas, and we continue to work with CMS to see if we can move them to eliminate some of them permanently that we feel after the public health emergency will be reinstated and we do not have confidence that they actually impact safety.
Yeah, we've been hearing that from a lot of hospitals and health systems across the country that, interestingly enough, COVID has given us the opportunity to find some gaps in things that we should have been doing differently and helped us prioritize what really matters.
Exactly.
and identify the things that maybe we didn't need to be doing or tracking quite the same way we were. But that raises a question for me. Our viewers are trustees primarily, and so I wondered if the two of you could speak to what is it that the board ought to be tracking or paying attention to, whether we're in the middle of a pandemic or just plain, finally out of the pandemic. I wondered if, Debbie, anything you want to comment on there?
So the board has a huge responsibility. And I appreciate that, as I mentioned before, our board is very focused on patient safety and outcomes. And I think we're all developing different ways to measure how we're doing with COVID. But another thing that I think that they've suggested that we focus on as well is employee safety. It's a huge time for really looking at keeping our employees safe. If we don't keep them safe, they're going to become part of the COVID numbers. So that's a big task. And the board has challenged us to really look at not only ways to quantify our outcomes with our patients, but also look for ways to quantify and encourage our employees to remain safe in the hospital, but also outside the hospital as well. And just to be really leaders in our community for setting examples on how to be safe and how to help keep your community safe as well.
I think we're beginning to address the next question that we had, which is moving forward, what should be the priority initiatives for increasing the organization's and the board's emphasis on quality and patient safety. And Dr. McKee, I know you also feel strongly about the need to focus on the workforce and their safety. Why don't you go ahead and add in here?
Right. I think this is a great opportunity for the board to explore and find new ways of evaluating organizational health, meaning the workforce, keeping them free of infection is very important, as Debbie stated. But also we know that there have been many second victims as a result of the stress and the extended hours that healthcare workers have had, and sensitivity to those issues, having the proper EAP support, employee support programs, and importantly, in many organizations and in many states, reaching out for mental health has implications for an individual's privileging and credentialing. So those barriers need to be removed. Staff need to be encouraged and supported. And I think this is where the board can have presence. This is an opportunity for boards to be side by side with their frontline workers, doing, of course, wearing proper protective attire, but speaking to the staff, acknowledging the sacrifice that they have made and supporting them, making sure they have what they need. The board needs to get into that conversation. And I think after the pandemic, if boards continue to have that direct conversation with frontline staff, I think that's going to advance us quite a bit in quality and safety overall.
So one question I would have is, it's absolutely important to make sure the board is taking care of things they need to take care of. Sometimes board members would hear something you just said, like you should be engaging with the front line. And sometimes board members feel they ought to be rolling up their sleeves and getting in there and doing the work of the clinicians or the managers. What advice do you have for boards about how to draw that line, between the board's role and the management and clinicians' role?
They're there to provide aspiration. They're there to provide support. They're not there to get involved in the healthcare delivery itself. But I do think that we have seen our healthcare workers, never have we seen them this stressed.
Mm-hmm.
And we had already pre-pandemic began to identify the consequences to safety and quality from the burnout syndrome that we've seen.
Mm-hmm.
This comes on top of that. And so I do think that it calls for something beyond the normal, beyond the usual, in terms of helping healthcare workers heal and move beyond. And I do see a role. And for every organization, it'll be different. But there is a role for the board in this space.
Debbie, what are your thoughts around this conversation?
Oh, I agree with Dr. McKee 100%. I've seen, I think going forward that even leadership, so not just the board, but even leadership of the hospital, it's an opportunity to learn new and different skills sometimes. It's hard to watch your staff be exhausted. And I've really admired the leaders in our organization right now. We're at a, knock on wood, a bit of a lull with our COVID cases. And so right now they're making sure that people can get vacations. And they're really encouraging that mental health and safety that goes with our staff. Throughout the whole crisis, they've very much had a lot of opportunities for even mental wellness for our internal folks. We have a very strong physician resilience program that has never stopped. In fact, it's just picked up more speed and more speed as we've gone through this crisis. They offer weekly offerings for physicians around resilience and mindfulness. And these are all things that also play into patient safety and outcomes. Exactly. If your staff and your physicians aren't 100%, they're not going to be able to give 100%. Mm-hmm. So throughout the COVID event, we've worked closely with departments that we don't typically even work with. Patient safety doesn't usually work a whole lot with HR. And because of all these needs of our employees, of our patients, of their families, HR has been just a great help and ease and comfort. They advocate for everybody. And so I think that, as we talked about innovations during COVID, I think that's some of the innovations that have come into place too. I think we've all come to appreciate our EVS staff more than we ever have in the past. Those are some more true heroes of healthcare that have come out. And so I think that moving forward, I would really love to see boards take that charge where they remember all of these different folks and help make sure that they can stay important and that they're thought of in all the initiatives that the board plans for going forward.
Mm-hmm. Dr. McKee, any other suggestions you have for priority initiatives for enhancing quality and patient safety?
Well, I think a good beginning would be for the board to commit itself to a curriculum to improve their competency and understanding. I think in healthcare, we take it for granted. We speak to everybody as if they understand our technical language. And I think that as a first step commitment is a wonderful place for organizations to begin. And really, the clinical leadership who's in charge of the quality and safety should take pride in putting that together. It's a way of them engaging with the board, but also for the board to be able to be more appreciative. It's not fair to think that they can oversee what they don't understand. And usually on boards, we have very successful people who do not like to be put in the position of not knowing. So we just have to give them the information and bring them along. And I think that that's an excellent first start for organizations.
Yeah, I would agree. The boards that I know of care very much about doing the right thing. They just don't have the education, expertise, to know what questions they're supposed to be asking. Debbie, how do you and your organization help translate the clinical information to the board members so that they can really, do their jobs?
So we bring them information. Excuse me. We make sure that they're up to date with regulatory changes and things that are coming down the pike that way. But at the same time, we try to associate stories that make it personal so that they can understand. We encourage them, and they all frequently participate in different training. So we've had board members go to IHI with us for additional training, and it gives them an opportunity.
For Healthcare Improvement.
Yeah.
Sorry. That's one of the things that we tend to do in healthcare. We use, acronyms that people.
You're absolutely right. So it gives us an opportunity to do just that. It gives us the chance to expose them to other healthcare folks. And it gives the healthcare people an opportunity to hear a different perspective, which we all need to hear. Dr. McKee mentioned earlier that it's important to have a diversified board because they bring knowledge from their industries that perhaps in healthcare, sometimes we get stuck in a box. And if we can learn from aviation or, nuclear power or finance or any of those, it can bring in perspectives that we may not have thought of because we're used to doing what we've always done. So I think that we all learn from each other, and we just have to keep that going. In healthcare, your learning can never stop.
I'd also like to add to Debbie's comment about diversification. Diversification in discipline is important, but let's not forget that diversification in race, ethnicity, and gender is also important. Boards should be making an effort to represent the community they serve. Amplify on the point that Debbie was making about diversity. It's important to have diversity in professional types and of different disciplines, but let's not forget that it's also very important to have diversity in race, ethnicity, gender, because organizations really should have a governance structure that really looks like the community they're serving.
And that even includes, in some cases, what I'll call geographic diversity, making sure you have people who are from maybe, in your case, the outer areas of your service area, as opposed to just those who are in the inner city. And often people's life experiences and perspectives are colored by what it is that, they have to deal with every day. Exactly. And so I think diversity should be thought of very broadly when we're talking about making sure our boards and their committees are reflecting the communities that you're serving. Great. Any other advice for your colleagues? By that, I mean those who are serving on boards and those who are helping boards understand quality and safety issues. Debbie, let me come to you, and then we'll end up with Dr. McKee. Any other advice, Debbie, for trustees of hospitals and health systems?
Okay. Go ahead and make sure that you're explaining everything to your board. They are there really to help and support you, but don't assume that they understand things. There's different measures that we use in quality that might have different meanings to different folks. So break it all down, use common language, and just make sure that you're bringing all the points of view when you're telling your story, because there's so much intricacy in healthcare that it's important to make sure your board understands all of the inputs and outputs for the data and the information that you're bringing them. And then also be open to listen to your board. They have a lot of great information.
Thank you. Dr. McKee, any closing advice you would have for trustees of hospitals and health systems?
Sure. My parting words would be, number one, you've assumed an enormous responsibility, and it takes a lot of time and commitment. And so I applaud trustees for taking on that responsibility. And I would say don't delegate. Don't delegate that responsibility as something that we see oftentimes where the medical staff is sort of held accountable, holds the accountability for quality and safety. That has to sit with the board, with each trustee. And I do think that a trustee has a tremendous opportunity to help healthcare advance and accelerate in patient safety. We're not moving fast enough in making improvements. And I think getting the board engaged will make a big difference.
Mm-hmm. Getting the board educated, having the right people on the board, engaging them with information that they can understand will help all of us create healthier communities.
Absolutely.
Great. Susanna, let me go ahead and turn it back over to you.
Thank you so much, Pam, and thank you, Debbie and Dr. McKee, for your time. I know you both are incredibly busy, and really appreciate your conversation, your experiences and advice around patient safety. Certainly your perspectives from a clinical, a governance, a community, and even a historic standpoint will certainly resonate with our membership. So thank you, thank you. To further Debbie and Dr. McKee's point on continuing education credit is available for listening to this program, so please visit tht.org/straight talk to download your continuing education form. Additional information about our speakers, as well as relevant resources to this topic, including articles and sample tools, will be available on our website. Please note that episodes of Straight Talk for Texas Trustees will be dropping on our website monthly, so please keep an eye out for our next conversation. Thank you again to our participants today and to Pam, and have a wonderful day. Thank you.